All right. Welcome, everyone. We're going to give it just another minute or two. A lot of people joining. All right. Still a lot of people joining. Welcome, everyone. If you just got in, we're just giving it another minute. Okay. Can't hear anything. Okay. Can anyone hear me? Oh, okay. Great. Perfect. Justine is muted, but everybody's responding right now. Good. All right. All right, I want to post the slides. Justine, could you allow, I don't know why I don't see an option to write or make me the host. Sorry about that.
That's okay. You know what? I think I can.
Oh, I can reclaim host. Got it. Aha. All right, everyone, I'm going to be sending right now the slides, some handouts that Justine is going to be talking about throughout her webinar, and also our ABA calendar and our psychology calendar. So you're going to get that right now in the chat.
And Kristen, I think you need to give me the ability to share my screen.
Okay. All right, we're going to get started. Before we get into the topic, I just want to introduce all of you, if you don't already know, about Manhattan Psychology Group. Before we get started, I also wanted to let you know that there's going to be 2 codes. So just make sure that you would copy those down. There'll be about 30 seconds for you to jot it down. Once the code is off the screen, we won't be repeating them. So please make sure that you're paying attention and then you're writing those down, because you're going to need to input those into the survey so that you can get your certificate. You should be able to get the certificate within a couple of days if you complete the survey in a timely manner. I'll also be posting that in the chat as well. And at the end of this, so we're going to be ending maybe about 3 minutes before 8 o'clock. And Lakin, our recruiting specialist, is going to be talking about opportunities with Manhattan Psychology Group. So if that's of interest to you, stick around. Lakin's going to talk for a bit about that. Okay. A little bit about us as a company. We're a multidisciplinary team. Lots of different psychologists, BCBAs, special education teachers, therapists, and we provide wraparound care across all of the boroughs. We have DOE funded and private pay clients, as well as insurance-based clients. We have tutoring clients. So a lot of different opportunities to mix and match if you're interested in working at Manhattan Psychology Group and you want to know more about that. I just wanted to share also our mission and our vision with you. Let's go next. Our vision is to create a future where individuals and their families feel supported, connected, and empowered. And our mission is to provide multidisciplinary integrated support for individuals and their families who experience mental health, behavioral, and educational challenges. Okay, This is Justine Caputi. So she is actually a supervisor and our training specialist here at Manhattan Psychology Group. She is awesome with treating selective eating, and I've learned a lot from her over the past couple of years. So I'm really excited for her to share this information with you. She's been with us for a couple of years already. Justine, how many years have you been with MPG?
No, 3 or 4, I don't know.
At least, yeah. More than. And so I just want to welcome her, and we have such a great turnout. So thank you, all of you, for joining tonight, and I hope you learned something.
Okay, hi everyone. Hi, welcome. No matter how many times I present via webinar, it never gets less weird, right? I'm like talking into a black hole to everyone at home, but thank you so much for joining us so we can chat about selective eating and picky eaters and behavior analytic strategies and how we use them with our clients. I hope everyone is comfortable and has whatever beverage makes you happy at this time of day. I have my water. So let's get talking. So yeah, this is an area that I've just had an opportunity to focus on with students and clients just through practice. I'm a BCBA like everyone else. I've just had opportunities to practice some of the research-based strategies with students and clients. But I like this type of programming, and I think it's because it's hard, right? You know, it's hard. I think I would put it up there with like sleeping issues and toileting issues, and then we have our eating issues, right? But we can make such an impact using what we know about behavior analytic practices, and it can be really rewarding in that we can really make a difference in our students and clients' lives. And you know, when we see, sometimes we'll see progress with us, but then generalizing to parents can be really hard. And so then we get to like, you know, do all this training with parents, and we can get creative. And so we can make it fun. So some of the topics that we will go through today, what is selective eating? How did we get here, right? Identifying selective eating behaviors as a target skill, what we target. Getting started, how we like get this treatment plan off the ground. We'll go through some real talk, proactive, reactive strategies, and like what this looks like in practice. And then we'll briefly go over some parent training because everyone here is in a slightly different role. And so your training and involvement in that might look different. So we won't spend too much time talking about that. Okay, so what is selective eating? So from a parent's perspective, it's probably something like, my child won't try anything new. They only eat stuff if it's hot, if it's not touching other foods, all of this, right? And it varies depending on who we're working with. The limited diet, like I said, those specific food preferences, it all occurs on a broad continuum. ARFID, I think, is important to note here because it's a new-ish, I think, eating disorder that a lot of medical practitioners are diagnosing. And oftentimes, once children are diagnosed with ARFID, parents at some point may seek behavioral interventions if that's recommended by doctors. And so I think that's just important to note. ARFID, for those of you who don't know, it's avoidant restrictive food intake disorder. And it's just like very specific, higher magnitude behaviors around avoiding eating certain foods. So just wanted to mention that. So some data. How common is selective eating? It's most prevalent in individuals on the who have been diagnosed with autism. So just know that, but some data here to reference. And we have a poll question here. So we'd love to know from all of you, have you worked with parents on food eating behaviors in the home, just to get a sense? And I believe, yeah, here's the poll. right, looks like we've stopped the poll. All right, so there's our data. I'm going to stop sharing this. I'm just going to X this out. I think I can hit share results. Okay, there we go. Okay, so how did this client student become a selective eater, right? So we probably hear this a lot from different families. Oh, hold on, I'm going to close that out. So we probably hear this a lot from families that, well, I make this for us, and then I need to make different food, or I choose to make, because we eat at different times, different food for my kids, right? Not offering a variety of foods on a regular basis because it doesn't work out and it becomes too hard, and I just like need to give them exactly what I know they're going to eat, and I stick with it. But what we know about behavior as behavior analysts is that behaviors are learned over time through routines, through consequences. And so we should be thinking about eating behaviors in this way. And what happens at mealtime is certainly a factor, and we're going to talk about all of that, but it's not the only factor, right? There could be medical issues, genetics might play a role, medical issues being the ARFID I was talking about, problems with sleep. And not everyone thinks about problems with sleep as being a contributing factor, but think about it. When we have a lack of sleep, we're less likely to, be compliant with, with things in our day-to-day, and we're more likely to be less flexible with things, right? And so we're more likely to do what we don't want to do if we sleep well. So that could absolutely be a factor, and it's worth talking about with families and questioning that. But children develop a pattern of selective eating over the course of weeks, months, years, right? And that means that we're looking at behavior reversal, right? So we're up against some thick patterns of behavior and looking at teaching new behaviors. Patterns of selective eating is the result of learning in most cases if clients are at a point where they're still seeking behavior interventions for this, right? And so learning to eat a wide variety of foods will take active practice. Oftentimes you'll hear parents say, well, I tried this for a little bit, didn't work, had to make this tweak. What we're hearing as behavior analysts is like, ooh, dropping a change in condition line way too soon, right? We didn't try it for long enough. We weren't consistent enough. And research shows that children do not increase diet variety unless they actively learn to do so, which means a systematic approach, consistency, right? Think of it like riding a bike. And I say this sometimes to parents, that if you're teaching your child to ride a bike, you wouldn't, like, the first day they get on and they can't do it, you wouldn't give up, right? You would stick with it until this skill is learned. And eating behaviors, for the most part, can be looked at in the same way. Okay, so factors that can affect eating: associations, right? Association of certain foods with symptoms of being sick. I'm sure we all can think about at one time, maybe there was something we smelled in the presence of food, or we tasted something or ate something and then got sick, and it's just like, that conditioned aversion has occurred. That can happen with children too. Conditioned taste aversions can take one time, can be long lasting. But it's important to know this history because it plays into selecting the foods that we're going to introduce with our students or clients. So how and when, I'm just moving this over on my screen. How and when do we identify selective eating behaviors as something we need to work on? Hearing this from parents and caregivers, something like, I can't get anything done around mealtime. It's completely soaking up hours of my evening. They're grazing, they're eating all these different things. Tantrums are occurring. It's interfering with siblings. We can't go out to eat. I can't send them to sleepaway camp without sending them specific foods, right? Maybe we've observed that there are some eating behaviors that need to be worked on. I want to give a social validity warning here, though, because we need to be careful with this. Sometimes with eating behaviors, what might look inappropriate in some way to us might not be inappropriate for the family that we're working with, right? There may be certain cultural practices when eating, like eating with hands, or maybe not eating together. So it's important to just ask questions, observe, and gather all the information before making recommendations or going into your treatment plan. Eating behaviors may lead to stigmatization in some way, right? There could be some idiosyncratic behaviors when eating food, picking, licking, slurping. There's been studies done that show that people will report like the number one thing that might be a turnoff in the workplace for people not eating around other people are some of these idiosyncratic behaviors when consuming food that gross people out, right? And if you are working with a client or a student who is looking to go into the workplace, if parents haven't identified that this is an issue for them, because it's okay at home, it may be worth a conversation about, we're looking at this next placement or this opportunity. This may be something, it may be time to work on this, but that's just worth a conversation. It can be limiting moving forward in social interactions and opportunities, right? Not only in maybe these like workplace situations I'm talking about, but certain eating behaviors may be limiting for like families having people over to eat and traveling and all of that. Limited diet is leading to a lack of nutrients. That's another time, as identified by a doctor, where they may say it's time to work on some of these eating behaviors. There's no medical issue, but it is affecting their health in this way. So you may want to seek behavior intervention. Okay, we have our second poll question. Have you had success with food toleration programs in the past? Either you've observed success of another therapist or experienced success when implementing yourself. Okay, results are in somewhat, and yes, a little bit, not at all. I'm going to stop sharing. Ooh, stop sharing. Sorry, clicking through. Okay. All right, so getting started. So before you begin, make sure that you've ruled out physical or medical conditions before treating these eating behaviors as such, as behaviors, right? There is no one size fits all approach. And that is what, to me, makes all of this programming and all of the programming that we do so much fun, right? We get to carefully curate a treatment plan for this client, right? It's important to remember that you're going to celebrate every success, just like any skill that's acquired in what we teach, right? No matter how small, for the client and for yourself too, because this can be hard. Never feel defeated. You can always go back to the last step that was successful and build back up, right? Slow and steady wins the race. And it's important for you to feel confident in that when working with other providers, working with other staff, working with family members. So just keep that in mind. Okay, so as you're getting started, take a peek and ask questions. Parents have probably reported to you what's happening. And you might be observing something in your session, so you're getting eyes on it. But if something is only happening at home, or maybe you're not there for all of the opportunities, try to get eyes on it. Maybe take a video if you can. That can be super helpful. Gather some good ABC data, right? Look at all of the antecedents that everyone else who's seeking your help hasn't looked at, because that's not their job to look at it, right? The consequences as well. Dig into that. We do have a sample ABC data sheet that we're sharing, so feel free to reference that. Parent caregiver reporting. Ask questions, even if you're working on this at school, right? Parents and caregivers are such a valuable resource. We should ask these questions. What does the behavior look like? When does it happen? What do they do when you, right? We need to be really good detectives, because oftentimes parents will share a situation with a lot of information. And you kind of have to parse out like, oh, so what does that look like? Or what did you do right before that? Try out information, right? They might not say the consequence. They might say like, so then we just like left dinner. What did that look like? Like, did someone say something? Did you get right up and heat up a different type of food? Like ask all those questions. And then my two favorite questions: when does this not happen? And oftentimes parents or caregivers or anyone will have a hard time answering that question, because when behavior is all consuming, it's hard to think about like, when is this not occurring, right? It's happening all the time. And then also asking, what is most important to you in all of this, right? What do you want the big takeaway at the end of this to be? And that really helps us as the people who are helping with the treatment plan to identify a hierarchy on what is going to be worked on. Okay, you also want to ask questions about what's preferred and non-preferred, what they like and don't like when it comes to food. And as you're gathering this information, see if you can identify foods into categories and patterns. So texture, color, flavor groupings, pairings. Like they like to dip their food in things, and like, they're successful in eating foods when they get to like use all the dips or something like that. Identify patterns, because you might be able to use that later. And then outside of food, like what's preferred? Learn about this child, right? Games. Do they like different types of social interaction, jokes, certain items, getting out of things? Some kids love getting out of doing stuff, right? Maybe getting more time with something that's usually a little bit restricted. And find out non-preferred things. Maybe they hate doing chores, maybe extra homework or doing homework in general. Maybe they really become upset if you take something away or lose it. You would want to know that, because maybe you'd want to avoid it in your treatment plan if that's something you might build in. So just ask all that good stuff. Okay, this is our first code word. Code word 1 is tantrum. We're going to post the codes here. It's posted right now that's needed to get your CEUs, and I'm verbally saying it, tantrum. Once we move on, we're not going to repeat them. And to get both code words, you'll need to stay for the entire webinar and complete the survey that's shared at the end of the webinar in order to get your CEU certificate. Okay, tantrum is that code word. All right, I'm moving on. All right, so the final piece. Oh wait, I'm sorry. I just skipped something. So things we know when it comes to behavior, things that we just need to keep in mind. We know tantrums are reinforced when kids get out, or people, right, get out of doing things on the heels of a tantrum. Tantrums may be reinforced by gaining access to the highly preferred things, following refusal to do things, like eating new and non-preferred foods. And tantrums may lead to caregiver attention. And we know this as behavior analysts, but just remember to keep in mind. And the caregiver attention takes so many different forms, right? And so we need to be paying good attention to that. It might be a glance, a smirk, shifting in seat, right? Though that's why looking at a video or observing all of this is so important, in addition to gathering information from the team we're working with. So the final piece, as we're getting started, know your client, know who you're working with. What are the levels of understanding, right? What do they respond best to? Text, pictures, verbal instructions, right? Maybe like a video of their favorite character saying something. What is the level of understanding? And then what is currently effective as far as systems go or contingencies? where other skills have been acquired. See if you can use any of that here for this very difficult thing. It'll reduce time. They won't have to learn a new system, right? It'll save you some time on like the material making end of things, but look to see what's available and successful. First then board, some type of token economy or motivation system, a behavior contract, or maybe escape extinction. Maybe like follow through to show they can't get out of something just has been an effective strategy for them. It's not effective for everyone, but maybe it's effective for them. And then ask yourself, what can be generalized? What will make that possible? I'm sure we can all think of clients or students, that we've worked with where you as the provider working with them have been able to have really strong instructional control, right? They are so motivated to work with you, and you can like say a thing and their behavior changes. And then parents will be like, what? Like, I can't do that thing. So make sure you know not only the client you are working with directly, but who this will have to generalize to, who is also going to be implementing this treatment plan, either now or in the future. And that takes a lot of work, but it really is the payoff, right? And you don't need to have all the answers going into it, but you should be anticipating that and also thinking and being ready, like as you're training or working with others, where you may need to make tweaks for at the end of the day, this being a successful, meaningful change for the client, and not just you being able to say like, well, they do it with me. Like you have to figure it out. Like, no, that's not what we do. That's not what we should be doing. It's not about us. It's about making change for the client. So think about generalization ahead of time when it comes to the people you're working with and the person you're doing it for. Okay, so next step. Once all areas have been identified, we're ready to start thinking about our proactive and reactive strategies. So we get to craft our antecedents, right? This is our time to set it all up for success. So think about the time of day. When am I going to start working on this? Is it going to be a good idea to work on this during mealtime or maybe outside of mealtime? That's important. Location, location, location. Are you going to do it at a table where meals take place or at a different table? Remember, we know this. Locations can get contaminated so quickly, right? So just think about where you're going to do it. Visual stimuli. What are you going to have to prepare either before the session or in the session? Visuals can be so much more effective than us just like saying a thing sometimes. So think about that. Other material, maybe there's music playing in the background because that's a preferred thing for who you're working with. And it might make it more motivating to be doing what you're doing. Using a timer, maybe an iPad while eating is happening. That's okay for some families, right? So think about that. Then food, the type and amount, right? What are your targets? How much? And then how we're presenting this. What's going to be said, our SDs, right? What's going to be said or presented visually or shown to evoke our target responses. You just want to make sure that you are doing as much as possible proactively, so you have to rely less on our potential correction or some of the backpedaling that can happen. Maybe you want to really teach and use a system that's going to set the client up for success. And so if they can be successful with one thing and then you move to the harder thing, do that thing. Okay, so now we get into our options for ways to present food. So let's start easy, right? You want to reduce response effort when possible because you're working on this because you already know it's hard, right? Maybe your first targets are introducing foods that are very similar in taste, very similar in color, similar in texture that's in the current diet. Thinking like a Cheez-It and goldfish, right? Same texture, color, taste is the same, but the shape is so different. The size of the taste does not seem to matter. Oh, small is okay, right? Keep only what is expected to be eaten on plate, spoon, or fork. You know, we're visual creatures, if you can see, right? We can be visual in this way. And all of us can, right? You know, you're at a restaurant and a big plate of food is delivered by your server and you're like, whoa, that is so much food. I'm never going to eat all of that. And that's a food that you like to eat because you ordered it, right? Think about these behaviors we're working on. They're hard for who we're working with. And so that same effect can be in play. So think about only putting on the food, on the plate, the fork, the spoon, the amount that you're expecting them to eat, because that visual presentation, especially if it's a food they find aversive, like all those chicken nuggets, but you only want them to take a bite, like as the target, no need to present that big thing. Just only present what's expected. If it applies, try to use foods that are that have been previously eaten, or even start with preferred foods. Teach them the system using a food that they like, so they come in contact with success with those visuals, with that system, with accessing reinforcement. So it helps to build momentum, which we'll talk about a little bit later, but it builds momentum to be like, oh, this system works. There's consistency, there's control being built, there's trust being built, right? Maybe you move to new brands of similar foods. So like maybe you move from Burger King fries to McDonald's fries. And you may want to start with low texture foods depending on your client, because it's just like easier to chew and swallow, which is a piece of consumption, which we'll talk about in a little bit. And then oftentimes access to choice is a function of many of these eating behaviors that we're working on. So think about providing as much choice as possible for clients who are able to reliably make choices, right? We all know those clients who it's not a reliable choice. So make sure if they are able to make choices, maybe you build that in. Maybe they choose the new foods that they want to try. You can build in providing restricted choice. The case study that I'm going to go through in a little bit, that was a case that I used restricted choice for. It was really successful. You can say, here's what's for dinner. Do you want to eat this or this first? Something like that. Or it's time to eat meatballs. Do you want 2 meatballs or 3 meatballs, right? This is what you're eating, but you get to pick the amount, right? And make sure when you're selecting choices, pick choices that you can live with. Talk to families, caregivers about this. Make sure that you're allowing choices that everyone can live with and is comfortable with. Okay, so now we're going to get see what the research says about strategies that should be used with selective eaters. I just need to move this again on the screen. Okay, so most food selectivity interventions include a treatment package of sorts. And actually, in like speaking from my own experience, all of the treatment plans have included multiple components that leads to success. Most of them do involve fading in some way, fading in or fading something out, differential reinforcement. Escape prevention is really limiting at home, but in clinical settings or more structured settings, it can be really effective. So some alternatives to escape prevention, because that can be really hard at home. Structuring meals and avoiding special meals. This is where we talk about like cutting off snacks, right? Create a state of deprivation for eating, right? Simultaneous presentation, plate A, plate B interventions. I'm going to talk through that. We're also going to talk through behavioral momentum. In our handouts, we have some examples of like good behavior charts and a behavior contract, and then modeling. Okay, so simultaneous presentation. I might go too far for a second. Ooh, yep. Okay, we're going back. So simultaneous presentation. This is the effect of I only eat eggs with ketchup, right? It can be a really effective antecedent approach to introducing new foods. Mix new foods into preferred foods in tiny amounts. And then maybe you slowly change the ratio of new to preferred food. Or maybe you don't. Maybe you learn that, wow, they just like these foods that are put together. I love thinking about all of the research and the application piece as far as like real life stuff. Most people like foods that are mixed together with something, or maybe they like their peas sauteed with some onions, right? But when you talk to people, they're like, oh, I've only given them peas, like, yeah, like right out of the can, and I heat it up because like they just need to eat the peas. It's like, well, maybe they need a little flavor, right? Maybe they need a little simultaneous presentation to increase that preference. It's worth a try, right? And research shows that simultaneous presentation in a few different ways can be really effective. So think about using that. Maybe putting the new food and the preferred food on the same utensil, right? Like maybe a little mashed potato with that turkey that you're trying to get them to eat. Maybe the combination will be life-changing. And it's called flavor conditioning. And so that's a strategy that can be used. It's also important to think about the introduction of the flavor conditioning. It's important to be mindful that, like, I want to say this correctly, but like parents sometimes will say, well, she likes red sauce and she likes chicken, so I don't understand why she doesn't like chicken parm, right? And the food's separate and then together, it should be considered a new food. The chicken parm and the chicken and the marinara, that's 3 different foods, right? And so it's just important to think about that and actually correct parents and say like, well, it is different. And it can go either way. It can be a good thing because then you get them to eat more foods or whatever the goal is, or it can be, you need to parse it out in some way. So just think about that. Hey, modeling. Your behavior matters too. There is research that shows that caregivers who do not model eating, drinking, consuming certain foods regularly are more likely to have children. Oh, wait, did I read that right? Caregivers who do not model drinking soda, eating candy and sweets, and so they eat healthy, they are more likely to have children with healthier diets and weight, right? So think about that. If you are dealing with a family who is eating different food than what they're serving their children, that could be it. So think about building in video models to try to increase eating certain foods. Use preferred people in those videos or in vivo, right? Peers, parents, caregivers. Most often foods are tasted upon appearance. And so if foods are being eaten by a preferred person, maybe more likely, right? Maybe you pair a student with a preferred peer at lunchtime if they're eating the target foods, right? You have lots of different options, but utilize modeling in this way. And then behavioral momentum. So I mentioned this a little bit earlier, but start small. Maybe you present an empty spoon first, build some momentum with that, and then you slowly increase the amount of food that's going on the spoon, right? It's also really important to remember here that consumption, when it comes to eating behaviors, is key. And I mentioned this a little bit later too, but eating and tasting something is like putting it in the mouth, chewing it, swallowing it, and like that's it. So getting to that point may be tricky. So starting with as small as like accepting an empty utensil into the mouth could be really successful. Then we have the plate A, plate B, where you're using preferred foods as the reinforcement for the non-preferred foods. These are meant to be brief sessions. I've seen this really successful in more structured settings like school. It's really straightforward. Yeah, you keep it brief. There's really no food consumption in between sequential presentation of the preferred foods. But yeah, I've seen this successful in schools or in school. Okay, and then we have using DRA, escape extinction, and fading. This is easiest to do in a controlled setting. And it's the practice of taking a bite and then you get to be all done, right? You take a bite and the reinforcement, and you can't leave the session or leave the area until the bite, like eating the whole thing, is consumed. And you would say something like, when you take a bite, you're all done. You repeat the rule every 30 seconds until acceptance or something like that. There's a break and then a new session is conducted. So it's quick, short, but controlled settings is where this is most effective. So setting expectations, be clear from the start. Clear is kind. And this is what I was talking about with behavioral momentum, but in the past I've tried, and I'm sure many of you have tried this too, like we'll start with a touch, a lick, stick your tongue out, taste it, and then you get to spit it out, that whole thing. And in my experience and in the data that I've assessed with procedures like that, there's rarely any progress. To develop a preference for food, the food really must be tasted, not looked at, smelled, licked, right? Because no one does that when they eat. They're never like, and then eat their food, right? If they do, that's probably a behavior you're trying to change. So really think about what is the end goal and get right to it, right? Rip the Band-Aid. Be clear from the beginning. This is what you are expected to do. This is what eating means. Blow through a little bit. If you have strong motivation in place, you may start to see a change, right? And tasting new foods, once you push past that, like that's the expectation. That's what we're looking for. Chew and swallow, right? It gets easier over time as new foods or portions or whatever it is are added. Teaching children to play with food is messy and it often can be a waste of time. And taste must occur repeatedly. Once or twice is often just not enough. And the research does show that, like I said, consumption is key. So we talked about antecedents, so now we're going to talk about consequences a little bit. So really looking at positive reinforcement, how we're using attention in a way that's reinforcing, what we're giving access to, and then negative reinforcement, what we might be taking away. And then if the consequences, if the client does not meet expectations, maybe you're delivering something that's non-preferred, like, ooh, extra homework or a chore or something. All depends, again, on who you're working with, or maybe taking away something that's preferred, negative punishment. We want to try to avoid, just like this video is showing, modifying expectations, getting into bargaining. And this is where we really have to work with parents oftentimes, because we know behavior analysts most of the time can be pretty consistent and have treatment integrity, but it gets hard when you train. We know that intermittent reinforcement is the most powerful schedule of reinforcement. And the clients will remember when they got out of it that one time, right? And that could be more detrimental the more sophisticated the client you're working with, right? And so it's just important to talk about going into the treatment plan. And put this in because it really comes into play when you're doing parent training, and it has such an effect on behavior, but what you do and don't do absolutely matters. It's important to make sure that you have control over what you're working with. And not only like the food, but also like your behavior, facial expressions, what's commented on by people who happen to be in the room, moving things around the table, shifting, what happens after mealtime. All of this matters. So bring attention to that when it comes to training. And take note of that when you're collecting your ABC data. Oh, here's our third poll question. Do you think food and eating behaviors can be shaped with the help of behavior intervention plans? do you think it can be? Sometimes. I like the sometimes. I'm liking the little percent. Okay. So you can see the results. Let's stop sharing. Okay, so here I have an example case. So what I did here was, in this dark blue here on the left, these are questions that I asked a parent. With this client was a young boy who was underweight, sought medical treatment or medical advice. There were no gastrointestinal issues, but underweight, there was lots of refusal as far as the amount being consumed, a grazer, the parents described him as. Not eating all of his food, verbal refusal, caused a lot of upset at the table, happened for all meals. They would tell him to eat, he would refuse to varying degrees, and sometimes he would just get up and throw his food away. Parents would let him not eat it. In the light blue here, this is all of what they reported. I pasted in their notes. They would let him not eat it. Then when he asked for dessert or other foods, right, he would shift to wanting other things, they would give in because they were so concerned about caloric intake. When asked, my two favorite questions, when does this not happen? Eating preferred foods like pizza, ice cream. What is most important to you? They wanted him to eat more of what he already ate. They were not looking to introduce new foods. This was about portions. So the goals we came up with: eat what everyone is eating at the dinner table, eating an entire portion that parents set, and eating at mealtime, not throughout the entire evening. He had lots of food preferences. This was a good thing with this case, but we were just looking to increase the amount of these foods. His preferred activities outside of eating, coding with dad and computer time. Non-preferred was not getting screen time before bed. Before I got started, this was during COVID, so I wasn't able to go into the home, but I reviewed mealtime videos that parents shared and took ABC data. And I was really looking at, in these videos, the interactions with food and when and how attention was provided, which became really important in my training for parents. So this is the example treatment package we ended up coming up with. It's a DRA and fading in the amount of food over time. So this was the flow chart for training I actually shared with parents. At the beginning of mealtime, they would give portion choice for each food item. And it was food that they knew that he eats. So they would say, how much do you want? Do you want this or this? And these were portions that they were okay with him consuming and they wanted him to consume. Either one that he would pick. They would let him know the deal. When you eat all the food that you picked out, you get to have programming with dad. That was consistently his choice. He wanted to do programming with dad. If he ate all of the amount of the food that he picked, he got his choice right after mealtime with dad. If he asked for more, that's just great. That's a bonus. If he doesn't eat all of the food that he picked, he would not get access to choice. If he asked to eat it later, he could get it, but he wouldn't get access to choice. That helped us hit our goal of eating during mealtime and not at other times. If he asked for a different food in the house, I told parents that he could eat it if that's okay with them, but he should not get the choice following the meal. That was to work towards our goal of not grazing and just picking different things, right? To eat what everyone else was eating. And this was successful over time. He ended up eating larger portions of the food because he was really motivated, and also did come in contact with not getting access, I should mention, over time. It took like 3 different meals before we started seeing a change. Behavior did experience extinction burst, and then it did change over time. And these were just overall notes that I also shared with parents outside of what was happening during mealtime. Increased satiation, or I'm sorry, a state of deprivation for screens and the electronics, because it was coding with dad that he wanted to do. Select portions he could be successful with, because we wanted to set him up for success, but also increase over time. So we use shaping there. Think about refraining too much conversation around the foods he doesn't like. In the videos I watched, there was lots of attention being provided around like conversations about texture and temperature. So we put those conversations on extinction. And then parent training. This is the end. And we just go through this briefly. Give parents the 411 real talk from the start. Let them know if you are working on this at home, right? What they're looking ahead to. This can be disruptive. You need to be ready to commit to working on something like this and just be honest with them, right? Because you don't want to have to get to a point where it's time to maybe push through a little bit in a good way, but they bail because they didn't know going into this that there could be a hard part that they hit, right? Some different parent training techniques, scripts, like I outlined in that flow chart, that was a script for parents. Role play, practice with them. It can be so uncomfortable, but then they're more likely to be confident going into mealtime or these sessions with their child. Modeling, use videos. Maybe they take videos of themselves implementing the treatment plan. And then you do a video review with them after they record themselves. Again, it's totally uncomfortable, but it can be so effective in helping them identify what they're doing that's positive, but also what needs to be changed. Okay, and this is our second code word, parent, P-A-R-E-N-T, parent. Okay, this is our second code word, parent. Again, you need to stay for the entire webinar to take the survey at the end to get your certificate. Okay, and then this is the training that I use most frequently with families. That is a training method that, I think most of us use in practice, but with parents, it's also successful. The I do, we do, you do with feedback. So model, rehearsal, feedback. Tell them what you're going to be doing or what they're going to be doing. Model it for them. Ask them if they have questions about that. Practice with them, and you can also have them practice with their child. Again, this could be uncomfortable for parents who are new to the process, but give lots of approval looks and like encouragement for the areas that they're doing well. Be genuine, give constructive tips, be clear. Clear is kind, right? Remember, procedures may not be as clean as if you were to do it. Get excited over small stuff and recognize how hard this might be for parents, because not being able to be successful at something with your child is really difficult. And that is the end of the training, and we open it up for some questions.
Amazing. Yeah, we have a couple of minutes for questions. The first question I have here is how many times, what does the research say, or is there any research that you know of that states how many times a child would need contact with tasting a certain food?
Yeah, I'm not sure off the top of my head the repeated exposure, but in practice, 3 to 5 times, like taking a week, like a length of a weekday, is typically successful in giving us enough information about what might happen moving forward. If that makes sense.
And here's a good one. What can we do when child shows gag reflex with food approaching his or her mouth?
So this makes me think that I realize I forgot to mention something I wanted to say with one of the slides, is that it's important to know when you're working on creating a plan, what the threshold is. When do you bail, right? Not only for a team that you may be working with at school, but training parents as well. Parents are going to have a different threshold than you because they're not behavior analysts, and you need to work with thresholds that are doable and going to allow you to move forward. And so gagging might be one of them. I would really suggest looking at the patterns of what causes the gagging, and maybe you leave those types of foods or odors or something for a while, and then reintroduce once success with other foods you've made progress with those foods, then go back to it once the system is more successful. But I would look into the patterns of the gagging.
Okay. I'm gonna ask a couple more. How do you know if the child actually does not like the food? I wouldn't want to force something I don't like to eat.
Totally. Take some data on like indices of what that might be. So like affect. We have so many clients. I'm not saying this is always the case, but we do work with lots of clients in our field that what they say expressively doesn't always match their behavior, right? And in that case study I presented, this came up with that client where he would say like, I hate this food, I hate it, as he was eating it. There were no other indices that he didn't like this food, right? And I watched that video with parents afterwards on mute, no volume. So does he look like he doesn't like that food to you based on indices you identify in your life as like not liking something? And they were so surprised because they never thought about doing that, right? So I'm not saying that's always the case, but it just goes to show you that they're like, really look at the indices. What's making you say they don't like it, and identifying that over time. Like test your hypothesis.
Good. We had a couple of people ask about working with nonverbal children, and also somebody asked about working with 2-year-olds.
Okay. Oh, what's the question?
Just like, if you have any like special recommendations for nonverbal population, and also because
with nonverbal students, I would say really look at your use of visual contingencies, your use of visuals in general, right? And also your reinforcement, right? The type of reinforcement that you're delivering to really change the behavior. Because having, those skills, the vocal speech is not necessary in acquiring eating behaviors. We're treating eating behaviors just like any other behavior. So any other behaviors that you're working on, there's strategies that you're utilizing or systems to teach those behaviors. Think about using those same ones for eating behaviors. And most likely it's going to be with like a lot of visuals. Maybe their PEC system is present. Maybe you're teaching command for escape. So using visuals, PECs, or an AAC device or something.
And would you say like that would be also your suggestions with a 2-year-old or with younger?
2-year-old? I don't know. I guess it totally depends, right? Like the whole treatment plan is so curated just for the level of learner that you're working with. It's not age-based. It's more about their skill set, right? Because we know that a 5-year-old client may have similar skills to a 2-year-old client. So, it's like age, it's more about their ability and what you can utilize to teach them skills.
Okay, great.
I think.
There are so many amazing questions. I think you've got everybody thinking, and it's so great to see. And I wish we could get to all of these questions, but we just have a minute left. And I want to thank Justine for speaking today and really getting through the research and making this really applied so that we can all take something home with us and try, with our clients.
Thanks so much.
Thank you, Justine. And thank you to all of you. There were so many of you tonight. So thank you for joining. And we hope you join again in June. We're going to have another event. So thank you, everybody. Just going to stop recording.